Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we focus on a discussion between expert faculty and people living with HIV regarding long-acting ART implementation challenges and opportunities. Joining me today are Dr. Iskandar Azwa, Dr. Beng Eu, Mr. Nikos Dedes, Mr. Jeff Taylor, and Ms. Bernadette Sharp. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear first from Ms. Bernadette Sharp, who will share her experience with switching to long-acting ART.
Long-acting LA, injectable antiviral therapy, ART, is one of the most exciting therapeutic advancements in the fields of HIV treatment in years. The currently available agents are indicated for treatment-experienced people living with HIV as either an option for switching to a completely injectable ART regimen or an injectable option in addition to oral ART. As a woman living with HIV, I have found LA-ART to be key to improving my quality of life and would like to share my story with you. How it started. The clinic in Melbourne where I seek my medical care was the site for a worldwide clinical trial for the injectable long-acting ART. I enrolled in the trial in 2018 and started treatment in 2019. I was happy to be part of this trial because at this stage of my life, I had been taking oral medication for HIV for more than 20 years. I was starting to miss a few doses every month and was thrilled to have a new way to take my medication. It also was fulfilling to participate in a clinical trial that would ultimately make the new HIV treatment option available to a much larger group of people living with HIV, managing adverse events. In the early stages of receiving the new long-acting ART, I had to take pain medications right after I had the injections and again before I went to bed. On the day of the injections, I felt quite fatigued and was not capable of doing any physical activities. However, as time went on, I started to feel a lot better and stopped requiring any pain medications during the day, but would still have to take them at night before I went to bed. I felt a strong discomfort the day of the injections, but the day after I felt back to 100%. As I continued to receive my scheduled injections, I started to feel a lot better the day after the injections, and I only had mild discomfort that did not require any pain medication. This was my body adjusting to the new form of HIV treatment. Fatigue and pain are relatively common adverse events associated with injectable long-acting ART, and now I have a first-hand experience with how it starts and improves with me, how it's going. For me, a woman living with HIV, injectable long-acting ART has greatly improved my quality of life. I no longer have a reminder to take a tablet every day, and I do not have to hide 2 to 4 months of prescribed oral medication in my bedroom cupboard from family members who do not know my status. For me, the process of receiving long-acting ART has become very easy as I receive the injections every 2 months. Because I am seeing my doctor regularly, I have routine health checks along with my injections. My lab results on the injectable treatment have been excellent as I have maintained virologic suppression. I am so pleased with the injectable treatment because it is very convenient for me. I have a busy lifestyle and the injectable schedule fits into my life perfectly. I plan to continue taking injectable long-acting ART because why would I change something that is working? Thank you.
Thank you, Bernadette, for sharing your personal story. Really appreciate that. So I'm going to talk a little bit about challenges and opportunities about implementation of long-acting antiretroviral therapy now. So these are the things that we think pose as challenges in the implementation. The injection administration, different processes of bilateral, essentially ventral versus dorsal approach for the injections. I think those of us who are a bit older who were trained differently face this challenge about just changing the way we give the injections. And a lot of clinics have gone through extra training to do that. It's not difficult, just something to think about. The frequency of visits, again, I think some clinics are feeling a bit challenged with that. And there are different models of how we can do it, about who does the injections at different times, but something to look at. Appointment bookings and the reminder system, because The injections need to be injected within a 7-day window, plus minus 7 days of when they're due. So it's important to have your appointments booked ahead. It's also important to have the appointments there in a way that, it doesn't get cancelled accidentally, or if a patient cancels, someone's actually aware of it. So, for example, at our clinic, we have an appointment system where rather than a regular appointment, they have appointment type which can't be cancelled until and the doctor has been notified if it's cancelled. So you just need different systems in place. Other simple things like supply chain, supply of the injectable agent and oral lead-in. You have to make sure it's available where you are. In larger cities where we have pharmacies around us, it's probably less of a challenge. In rural environments, you have to make sure the supply is there. Even with the oral lead-in, I've heard of some pharmacies having trouble getting the oral lead-in medication. So we have to make sure. We need to think about who is going to provide the medication. Again, every site's very different. In a city, we've got 4 pharmacies within 20 meters of us. So we just elect the pharmacy that's the closest and make sure they have supply. And some sites have pharmacy on site, so they need to make sure they can store the medication. In Australia, we have a direct courier delivery service as well, where it's delivered directly to the clinic. So some clinics are choosing to do that. Some really simple things we've never had to think of before is the cold chain. Temperature of medication is actually really important. So cold chain is usually maintained when it's being delivered and it gets to wherever it is. But the problem is that someone has to pick up the medication or get it ready for injection because it needs to be brought to room temperature before injection, so it's less uncomfortable. So you need to work out how that process happens, because also you don't want to warm up the medication if it's not being injected at that time. It can't be refrigerated again once it's been warmed up. So those processes need to be in place just to make sure there's no wastage of medication, yet at a minimal inconvenience to people having it. So there are challenges with it, but with them come opportunities. I think we can, as health providers and health services, we can actually pivot to actually get some opportunities. I think the extra visits can mean that we can do physical, mental health assessments, quality of life questionnaires, for example, things like that. We can talk about vaccinations, make sure everyone's up to date with vaccinations. We can deal with other medications at the additional visits. Timing of the injections every 2 months can be actually really good for travel. I have quite a few people who say that, as long as they have time to travel in between injections, it's very convenient. You don't have to think about carrying medications to countries where, it might be an issue having a HIV medication on you. You don't have to consider time changes when you're traveling, flights. But if someone's traveling for longer or it doesn't suit, oral bridging is available while they're traveling as well. So there are options. You can actually suit a lot of people. So first thing was, I was going to ask Bernadette, having the injectable therapy, has it increased your visits to the clinic, and has your clinic actually ended up providing you with additional services during these visits?
Look, it's convenient for me, I guess, because I live pretty close to the clinic, and I think every 2 months, so I do have the regular health checks at the same time. So I feel for me it's quite convenient and it's a very simple process.
And do you find that for you, the 2 monthly visits actually, do they suit you because of what you need for your other healthcare, or do you find it inconvenient having to show up every 2 months for your injections?
No, I don't, because when I first started the treatment, it was every month, so that was probably a lot more inconvenient. But every 2 months, it's just something I've adapted to, and it's it's very convenient.
Okay, good. That's good to hear. I've got a question for maybe Iskandar and maybe Nikos as well. What do you see as most exciting in the pipeline with the long-acting therapies?
Thanks, Beng. So, I come from a resource-limited setting. So essentially, I always have to wear my resource-limited cap on. So I think, and I think it's all about, for me and for a lot of wearing my resource-limited cap is all about equitable access. It's in the absence of a vaccine and in the absence of cure, I think long-acting antiretroviral therapy is highly exciting for the world. And I think it's certainly something we need to move the research agenda forward. If everything was equitable, I think long-acting cabotegravir and rilpivirine, from what I can see, is not really moving forward into resource settings as fast as it could. I think rilpivirine is not the best companion for long-acting cabotegravir, and I think lenacapavir certainly has more promise, but currently trials are lacking in terms of which injectable, essentially to make its best companion. Currently it's just oral therapy. But I think, lenacapavir is very exciting. To be able to give a long-acting treatment for every 6 months is highly exciting, but you want to do away with the oral therapy. Certainly some data that came up from CROI pairing it with 2 broadly neutralizing antibodies, shown very good suppression rate 6 months after. Is very, very exciting. It's very small, phase 1, I think about 21 patients, but certainly watch that space. But of course, it comes with limitations of access to broadly neutralizing antibodies, which really is unheard of, I think, in resource limit settings. And of course, looking at susceptibility to broadly neutralizing antibodies. So I think the short of answer to that would be, I think for us in resource limit settings, lenacapavir, but which partner to really partner it with at this stage.
Thank you. So about Nikos?
Yeah. Well, for people living with HIV, you've heard for how many years we've been taking treatment. We have reached the point when in many countries, patients go twice a year to the clinician. And before doing so, they do all their blood tests, and then they can engage in this discussion, take perhaps 6 months or a couple of prescriptions for 3 months, and it has simplified our life. Therefore, now having regimens that need to take us every 2 months may be seen as a step backwards, forcing us to go more often. On the other hand, I had my blood tests the previous week, and my doctor was livid because I had not been there since November 2021. So obviously, having something that has a regular visits to the clinic is something very important. And as Iskandar said, what we're looking forward is that this is the beginning, and that there will be long-acting regimens that can be there for 6 months or whatever. So I think that's the future, and that is what we're looking forward to.
Okay, thanks, Nikos. I also have a question for Jeff, and just asking about what you think about the pros and cons of having self-administered long-acting therapy.
Well, as a patient advocate, I really encourage the empowerment of patients to provide their own care. I mean, certainly over the course of the epidemic, people have a lot of experience with drugs like 220, injecting that twice a day, growth hormones, testosterone injections. So the experience is there, and a lot of people would love to kind of bypass, especially in the US, all the logistical nightmares of getting these drugs and just go to the pharmacy, pick it up, and give it to themselves. And I think also for other populations, people who've had the silicone injections in their buttocks, either to combat wasting or trans folks as part of their gender-affirming care, they need alternative sites, and you can decide where to do that. So I think, for many people, that would be a huge plus, and I think I look forward to us getting there.
Thank you very much.
I'd like to thank all of our faculty, Dr. Azwa, Dr. Eu, Mr. Dedes, Mr. Taylor, and Ms. Sharp for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on reaching the fourth 90, Can Long-Acting Agents Play a Role, on the Clinical Care Options website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.